Good evening, friends. Welcome to the international webinar series of CAHO and ISQua. And it's my proud privilege as Secretary General of CAHO to welcome you all to this international webinar series. So let me take this opportunity to invite Dr. Sanjeev Singh. He needs no introduction to the Indian audience and the global audience. Dr. Sanjeev Singh is going to be moderating this session. He is the Medical Director for the Amrita Institute of Medical Sciences, Faridabad, and the Chief Medical Superintendent of the AIMS, Kochi. He is a pediatrician by training, has worked as a regional coordinator at WHO India in a disease eradication program before joining AIMS. He is an improvement advisor at IHI. He is also an ambassador from India to Society of Healthcare Epidemiology of America. He is the international surveyor of the ISQua. He was responsible for drafting the accreditation standards of the National Accreditation Board, the 3rd and the 4th edition. He is presently the Vice Chairman of the Research Committee of NABH. He is the Chairman of the Technical Committee of HPI. He is a member of the Drug Safety Council, member of the Healthcare Committee at the Federation of Indian Chamber of Commerce, external consultant to WHO on regulatory licensing policy issues, and he is a technical advisor to several government healthcare projects such as e-learning, reduction of AMR, antimicrobial stewardship, and so on. So Dr. Sanjeev Singh is a great friend of CAHO. None of our programs actually happened without Dr. Sanjeev's presence. And indeed, it's a pleasure to have you with us, Sanjeev sir. And over to you to introduce Nancy and to take over the session. Thank you.
Perfect. Good evening. Thanks, Lalu. I am amazed with the work which you do and what have you created over the years. All credit goes to you. You are a magician. All credit goes to Dr. Vijay Agarwal. Such a fantastic team and such fantastic ideas of creating quality promotion and also involving 17 countries. Amazing. Very, very good and fantastic work. So thank you all for joining in, and thanks Dr. Vijay and Father Johnson and all the senior mentors of CAHO. We are here today, come together to listen to Dr. Nancy on a clinical audit subject. We know 2005, this national NABH standards was first laid down, and post that we have done fantastically well in almost all chapters and all standards and all objective elements. We have done well with many of the process re-engineering. We have done well with infection prevention. We have done well with facilities. One area which is still sort of pending and still needs a lot of attention is clinical audit. Unfortunately, though there have been massive clinical participation, and Lalu's organization is one which has done phenomenal work, there are many other organizations who have taken this initiative, but then a lot more needs to be done. It's a difficult topic, but then National Institute of Clinical Excellence has defined a methodology and they made it easy. We just need to have the mechanism right, the methodology right, the topic right, and look at outcomes, whether it is making a difference. So who better than Nancy could basically touch or educate us on clinical audit and its relevance. Nancy is a specialist in the subject of measuring and improving outcomes in quality and safety. She's a director of strategic services for Healthcare Quality Quest, a small independent organization. She has developed and refined clinical audit, quality improvement, and root cause analysis methodology, and developed standards for national clinical audit and designed and managed complex large-scale clinical audit. She is the author of Getting Clinical Audit Right to Benefit Patients and Getting Quality Improvement Right to Benefit Patients, both published by HQQ. She is also an author and co-author of guides produced for Healthcare Quality Improvement Partnership, including the Guide to Managing Ethical Issues in Quality Improvement or Quality or Clinical Audit Projects. She teaches and consults regularly in UK and has taught clinical audit in Bermuda, Botswana, Falkland Islands, Holland, Italy, Saudi Arabia, Taiwan in recent years. She's trained as a psychologist with the following qualification in the healthcare quality, that is certified professionals in healthcare quality, Healthcare Quality Certification Commission, Fellow of National Association of Healthcare Quality, Certified in Medical Quality, American Board for Medical Quality, Fellow Chartered Quality Institutes, Approved International Society for Quality in Healthcare, an expert and a member for Health Foundation Quality Community. Thank you so much, Nancy. That is, we are very, very good to understand that this is a phenomenal opportunity for us to collaborate together between CAHO and your institute. And we look forward to learning more from your talk. So over to you, Nancy.
Super. First of all, I just want to say how humbled I feel to be in the presence of so many people sitting in on today's session. So thank you from the bottom of my heart, really, for coming together for this presentation. I really, really appreciate it. And thanks so much to the organizers of this event for inviting me to be here. And thanks so much, Dr. Sanjeev, for that phenomenal introduction, just really highlighting everything I've worked in clinical audit. I've spent a lot of years working with clinical teams on clinical audit and measuring outcomes. And I just want to share with you mostly what we've learned and pass on the experience we've had so far. I'm going to switch, if I can, to a slide presentation and just take you through what we've done. Oops, I go to share slide. Now, in my presentation, first, I'm just going to walk through how we understand the clinical audit process and how we use evidence-based medicine to identify and measure care that links to the best possible clinical outcomes. I'll talk about how we integrate measuring outcomes and evidence-based with clinical audit here in the UK. And I'll also talk about the experience we've had over the past year in implementing on a pilot basis 4 national clinical audits for the Ministry of Health in Saudi Arabia. And just to demonstrate, again, links between clinical audit and measuring outcomes. And I'll end up with a summary of what we see as the benefits of using clinical audit to show you where the outcomes are currently being achieved. First, starting with the clinical audit process as we understand it, you've acknowledged already, Dr. Sanjeev, the National Institute for Care and Health and Care Excellence, it's now called, reviewed all the evidence related to clinical audit now over 20 years ago and published what's become more or less our standard definition of clinical audit. At the time, this was an important definition because at the time, people tended to think about clinical audit as large-scale collections of data about patient care. And NICE repositioned clinical audit as a quality improvement process. And that's really the definition that's really been sustained here in the UK since. It's first and foremost about improving care. It focuses on a systematic way of measuring, particularly care and outcomes, using explicit ways of measuring patient care, and if needed, implementing change for improvement. I'm going to take us through a little diagram that we prefer by way of explaining how clinical audit actually works. We start with the subject in clinical audit, and typically that subject has been derived by thinking in a systematic way about priorities for measuring and improving patient care. Then after we have a subject, the team involved in carrying out the audit, whether it's at national or local level, makes decisions about why this audit's being done, what's its reason, what's its objective, who is going to be involved in the subject of the audit, and more critically, who's going to be affected by the audit. Then we think about the cases, events, situations, circumstances that are going to be the focus of the audit. Here's where evidence-based practice fits in. So exactly what do we regard as best practice for this subject that we're doing the audit on? And I think more critically, how will we measure if we're delivering best practice? That's the link directly to evidence-based practice. At the next stage, we collect data, we go measure. How does day-to-day practice match up to what we thought was best practice? At the end of the data collection process, the shape in the diagram changes a little because it's a key decision. Now we've got our data. Does our day-to-day practice show that we're implementing best practice? I like this diamond shape because I always say to teams, the answer here is either yes or no. Let's take the positive side first. We decided what best practice is. We went to see what happens with our patients on a day-to-day practice basis in comparison to best practice, and we learned we're doing a very good job. People often say to me, well, you have nothing else to do with your audit then. And I always remind people, please feed back to all the staff who work very hard every day to deliver good patient care, that the audit shows that good practice. We often say to teams, celebrate what a good job you're doing. You will have to think about how you keep it up, because maintaining good practice doesn't happen automatically. Teams often ask, when we have good findings from an audit, do we ever need to repeat that audit? And basically, we've suggested, yeah, if anything changes, we've got massive changes in staffing, for example, key people have changed, or we need to make sure things are still as good as they were earlier. The other side of the diagram is where we see teams struggling. Day-to-day practice from our data collected shows that we're not exactly delivering best practice. We're not achieving the outcomes we want to achieve. Then we say, okay, what are the problems affecting care on a daily basis? What's causing those problems? What are the improvements you need to make? And then, having done that analysis, come up with an improvement plan and put it into place, and then repeat the data collection. There's a note on the screen, which we've gathered from the evidence base, as rapidly as possible in order to confirm that, in fact, the changes in practice you put into place have benefited patients. The red shapes in the diagram show exactly where quality improvement fits in to clinical audit. Now, just to draw out some of the key components of the audit process, when we're designing a clinical audit, we're very explicit about exactly what objectives we want to achieve. We think about, we call them stakeholders, who's going to be involved, who's going to be affected by the audit, and getting those stakeholders to participate in the audit from the very beginning so that they're fully aware of the process. Which group of patients, event situations are we including? Are we taking all of them? Are we sampling? What's our time period for data collection? Very specific questions at this stage that we answer. In order to compare our practice with good practice, we devise quality of care measures. There are 4 components made up of measures the way we use them. What's our evidence we're going to look for? What tells us we've done what we should be doing for our patients, that we're achieving the outcomes we want to achieve? We use the word standard here to refer to how many patients do we want to have achieved best practice. So we use that as the basis for comparison in our measures. Are there any very excellent clinical reasons, or sometimes patient-related reasons, why we were unable to provide evidence-based medicine? It may be we were supposed to prescribe a medication for a patient, but the patient happens to have an allergy to that medication. So obviously, that's a very good reason why we didn't. We want that noted in our measures. And finally, for those who will help us collect data for the audit, we need very, very good instructions about what you look for in a patient record, exactly how you decide that the measure has been met. You've heard me now emphasize how important collecting data is for a clinical audit. We've learned from a lot of experience that clinical staff will not change practice if they do not believe the data collected for a clinical audit are accurate. And so we go to great lengths to make sure that data that have been collected for a clinical audit are really reliable. Finally, the team looking at the carrying out the audit and looking at the data from the collection of data from the audit need to look for, is there any reason we can find why we did not deliver evidence-based practice, why we didn't achieve what we wanted to achieve? In reality, we sometimes find that when a peer group looks at what happened to individual patients, they uncover more what we would have called exceptions earlier, very, very good clinical reasons why a change in practice was implemented for a particular patient. We want to give credit when that's happened. Now, sometimes peer groups also identify at this stage that there are some patients who did not receive the care indicated by evidence-based practice, and there's no real explanation for why that happened. If that's the case, then this is where the quality improvement process takes over. What are the problems? What's causing the problems? What are the interventions we're going to try to put into place to achieve improvement after we've done that, repeating the data collection to see. Now, next, I just want to walk through quickly how we link evidence-based practice, particularly around outcomes of care and clinical audit. Now, the top of this diagram has to do with flowing through basically the evidence-based process, evidence-based medicine process. It usually starts with a clinical team asking a question, what should we be doing about? And they pose the question about a particular group of patients or a situation. Our first question is, do you know what the evidence base currently says? If so, fine, let's move on. If not, let's go find the evidence and appraise it and find out what current evidence-based practice says. Is that evidence based on a formal appraisal process valid and clear? Sometimes we find it isn't, that the evidence base itself doesn't give us clear directions for what might be appropriate or effective care. In which case, can we get expert opinion? Can colleagues who are experts in the field agree? If they don't agree, and sometimes even when they do, the next logical step is their own research, better designed, perhaps, to give us the answers that are still outstanding about the evidence. There's a little diamond shape that follows below is the evidence valid or clear that asks, are we going to implement the evidence? Because here in the UK, where what we call clinical governance is well established, that accountability at healthcare organization level for delivering quality and safe care. If we are not implementing best practice, and that decision is clear, then under clinical governance, we have a duty to inform the management of the organization that we're not implementing best practice and why. So that's why that little diagram, that little diamond shape is in the diagram. Here's the connection to audit. We know what best practice is. Is that what we do every day? Following the diagram I had earlier about clinical audit, do we have good practice? Fine. If not, there's that loop into improvement. And again, keeping people informed. So I think the key parts of linking evidence-based medicine and clinical audit is how the actual evidence is analyzed. How do we pick out key aspects of clinical care? that are directly related to achieving the best outcomes? And how do those aspects of care convert to clinical actions that should be implemented for each patient? That analysis is actually quite important, and selecting out of everything in the evidence base which actions are most directly related to the achievement of best clinical outcomes. And also it has to be reasonably feasible to implement the evidence in the care setting in which we're functioning. Now, there's been a lot of debate in the literature and among people working in clinical audit about whether we measure outcomes only in a clinical audit. And the difficulty that teams have sometimes encountered, if you only measure outcomes and you're not achieving the outcomes, you don't know which aspects of key process have not been implemented for your patients. So is it something we failed to do that means we didn't achieve the outcome, or is there some other reason why our care has not produced the outcomes we want? So we tend, from our experience, to suggest to teams that when you are interested in measuring outcomes, identify from the evidence base the key process linked to the outcome, so that you can see if we delivered our key process, did we achieve our outcome? And I point that out because we've learned over and over again that sometimes patient factors affect the achievement of outcomes. If patients, for example, are not compliant with the treatment you've recommended, they don't take the medications that have been prescribed for them, it may in fact affect your outcomes, but you've delivered the right care. Now, just briefly, I want to walk through how things work linking outcome measurement and our audit experience here in the UK. We have audits operating in the UK at two different levels. At national level, the priorities for improving healthcare for our entire population in the UK have been identified, and many of these priorities become the basis for our national clinical audits. These audits are based on evidence-based practice that can be published by our organization, NICE, or by a Royal College or another professional body. Then at healthcare organization level, each hospital, each clinic, each service that provides healthcare has its own local clinical audit program, in which each clinical service, teams in each clinical service, measure not only the national evidence, but they also select their audits they want to do on a local basis. They're all evidence-based practice, but they may be focusing on what's more important in the organization. So we've got national priorities focused on national audits. We've got local audits focused on local priorities. I say that because sometimes there's a little variation from hospital to hospital about what's important to achieve for our community of patients, for the groups of people we tend to look after. I have to say both the national audits and our local audits usually link key processes with that we know achieve best outcomes. Well, here's part of the list of our national clinical audits. There are about 50 in total, long list. They're funded through a combination of government funding. Some are funded by professional groups, and some are funded by charities that are interested in a particular service, for example, Parkinson's disease. Here's the second of the rest of the list, basically, just to show you the subjects covered in our national program and how broad they are. Some of the audits focus especially on outcomes. Our fragility fractures audit, for example, looks specifically at outcomes. Our joint registry looks at if you've had knee replacements, hip replacements, what are your outcomes longer term? Maternity outcomes, perinatal outcomes, medical surgical outcomes, mental health outcomes. Our national audits look particularly, those particular audits are very highly focused on outcomes, but all the national audits have measures of outcomes as well. Now, just a brief explanation, how do the national audits work? Well, for each national audit, there's a national group of experts and patients who have experience of the condition that's the subject of the audit. And they work together to design the audit, particularly to identify what's going to be measured about quality in the audit, specifying exactly the data to be captured, and sometimes the audits specify going to actual patients and collecting data directly from patients. The national group is responsible for gathering data from all organizations in the country who are participating in the audit, analyzing all that data, collecting all the findings, collating all the findings, and issuing reports. Both the reports concentrate at national level, where are we, but also each organization can see where the organization is in relation to implementing what's in the national audit as well. At local level, then the relevant clinical group collects the data required by the national audit and submits it. And then when the reports come out, they interpret their own data and act on their own findings to make improvements if they're needed. Our national clinical audit program here in the UK has been going on about 30 years now. So there is extensive literature on what our UK national audits have achieved in terms of improving outcomes of people living here in the UK. These are just a tiny, tiny sample of some of the outcomes that have been achieved. Babies having cardiac surgery, mortality rates been halved. Stroke units have made substantial difference, our stroke audits made substantial difference in having stroke units. Patients automatically go to the specialized units. Mortality, length of stay, rates of institutionalization following stroke, they've all been decreased as a result of this audit. Children with epilepsy, people with heart attacks, timing has improved enormously in getting them care and getting the interventions done. Parkinson's patients have benefited from the Parkinson's audit, which is actually sponsored by the charity. Now, let's talk about just very briefly, the impacts of local clinical audit, because that's a little more extensive. In order to have local audit happening, all the staff working in a local organization, hospital level, clinic level, and so on, have to learn the clinical audit process so that they can participate in audits on their own care. Every single clinical service in our healthcare organizations is expected to carry out audits each year on priorities that they identify for their services. And at organization level, senior management level, if you will, every senior management team is accountable for making sure that clinical services carry out proper clinical audits, including acting on the findings. Clinical audits have been recognized in other ways here in the UK. Doctors, as you no doubt know, are now revalidated every 5 years. And in order to submit your evidence for revalidation, it requires that a doctor has participated in clinical audit, has participated in quality improvement, and can show evidence of what that participation has been in order to be revalidated. Our doctors in training are required to do a clinical audit as part of their training, and that's now been extended to other health professions as well, pharmacists, for example, and therapies. At local level, there are numerous examples of how local clinical teams have improved the care they provide to their own patients through their local clinical audit. Now, how does this work in the system, if you will? Well, NHS organizations and other organizations that accept funding from the NHS to support the delivery of care, they all do this in line with what's called a contract for services. And in that standard contract, which is national, there are a number of references to clinical audit. At local level, the contract says you have to have a program of clinical audits in all the services, and your local commissioners are the people who oversee the provision of care in our structure. And they can oversee the findings of those local clinical audits and make sure teams have acted on the improvements they need to achieve. In the contract, there are a few audit subjects actually specified because they're so important to patient care. Safeguarding patients, patients who would fall under our Mental Capacity Act are treated properly. There's protection of data related to patients. All of that is covered in the contract. And all that is built into the way a local healthcare organization operates. At national level in the contract, healthcare organizations have to participate in national clinical audits for subjects that they cover, the care they deliver to their own patients, and make that data available to support the publication of that data at national level. And there is a small amount of payment made for NHS and NHS funded organizations to participate in the national audit. This all comes together here in the UK, and what's really enhanced the importance of clinical audit here in the UK is the introduction in 2009 of a new law that created what's called a quality account. A quality account carries as much weight in our healthcare system as annual audited financial accounts. This is an annual report available to the public from every provider of NHS services, and it's all about the quality of care provided in that organization. Just a quick summary, what's included in a quality account in part one is an overview of quality, and just as it is with financial accounts, the quality account must be signed as being an accurate and complete record of quality. It says by a senior person that's normally the chief executive of the healthcare organization. In part two, there's a lot of detail. What are the improvement priorities for the next year? What's gone on the previous year? Where are we with providing quality? But there specifically is reference to what's our participation in national clinical audit and other inquiries that happen at national level, for example, about patient deaths. Where are we with local clinical audits, and what's the evidence that our local clinical teams are acting on their audits? And also in the quality account, there's a requirement to talk about, if you're carrying out research, how many patients are involved. In part three, there's a comprehensive review of quality across the board in the organization. How have you involved key people in setting priorities for improvement? These stakeholders now can be community organizations, patient organizations, local political organizations, anyone who has an interest in the healthcare organization can actually submit their information to be included. So now I'm going to draw some conclusions about what our experience has been here in the UK. It's a very valuable process, clinical audit. But some lessons we've learned, I think, over our 30 years of experience with national clinical audits, the national clinical audit needs to be incredibly well designed and executed to engage the support of all the clinical staff. organizations leading those audits need to show leadership in improving quality and help healthcare organizations get there. There are those tiny incentives about participating in national clinical audit actually does help. Standards for how national clinical audits should be designed and carried out have actually been published in the ISQua journal, if anyone is interested. We authored those standards originally based on work we did here in the UK. The standards have now been applied, I think, in Scotland, Australia, and a couple of other countries undertaking national clinical audits. At local level, the management being accountable that clinical audits are carried out. It's built in now to our regulatory process, inspections that are made by our regulator, the Care Quality Commission. It checks on, yes, the clinical audit program is being implemented. That's quite fundamental. I said before, that means our professional staff have to know how to do it properly. The last point I'd like to make on the slide is the process really has to become part of the way the organization works. And I would say certainly here in the UK, clinical audit is just simply part of the healthcare culture. It's just part of the way we work now. So next, I'd just like to walk through with you the experience we've had in our organization over the past year in working with the Ministry of Health in Saudi Arabia on implementing for the first time national clinical audits on a pilot basis. So the Ministry of Health selected 4 subjects because these are the leading causes of death or disability in Saudi Arabia, and they're stroke, MI, major trauma, and sepsis. There are 300 hospitals in the Ministry of Health in Saudi Arabia. We couldn't include them on a pilot basis. 16 very large hospitals were selected in 2 cities, Riyadh and Dammam. I'm going to walk you through the pathway because it echoes the I've been presenting. We started with finding best practice for each of those 4 subjects by looking for guidelines published internationally. We were very selective about the guidelines. They had to be developed consistent with the international agreed collaboration on how you develop guidelines, and they had to present recommendations from the interpretation of data consistent with the international grade working group now. So very selective in how we chose the guidelines. Now, then we realized it's not feasible to measure implementation of every single thing in a guideline. All those aspects of clinical practice would make a very large audit. So we worked with Saudi clinical experts, and we had an international clinical expert for each subject to derive what we call clinical care standards based on the best practice internationally. What were the aspects of care most directly related to getting the best outcomes? That's what went into the clinical care standards, and I'll discuss that in a little more detail on another slide. Then we designed the clinical audits. We had workshops with all the teams from all the hospitals on the standards so that they knew where the standards came from and they knew the evidence base behind them. In each hospital, we had designated collectors of data for our audits. We trained them, and then that left the hospitals to collect data. Now, in the first pass at collecting data, we collected data before the standards were implemented. So we had a baseline of what happened before we introduced the guidelines, the guideline-based standards. After the hospitals collected data, just like our national audits here, we pulled together the data, analyzed all the data from all the hospitals, and sent back reports both at national level and for each hospital. So each hospital could see exactly where they are in meeting the standards and identify areas for further improvement in care. Hospitals had about 4 or 5 months to implement improvements, then we repeated the data collection. Again, exactly the same way as was done earlier, analyzed the data and sent back reports to show here's where the improvements have actually taken place. So just a little bit of clarity. Clinical care standard, when we developed the standards, we meant it's a very, very clear description of care patients with a specific condition should receive, consistent with best evidence. They were developed, as I said, by clinical experts. We used the Delphi process to agree on priorities. I particularly want to point to the criteria we had for selecting these standards. They had to be focused or centered on the patient. They had to be evidence-based. They had to have a direct link with outcomes. I'll show you some of those examples in a short while. We wanted our standards to be multidisciplinary because we recognize that care is real patient care is actually provided by a whole range of healthcare professionals. So doctors, nurses, therapists, specialists in rehab, health educators, emergency care, ambulance crew, all were participants and all referred to in our standards. And the standards had to be feasible for our hospitals to implement. We tested validity of the standard. And when we presented the standard, we were very fussy about it. The document had each standard explained. Why do we have this standard? What does it do for patients? Any key medical terms or clinical terms we explained in detail. But the last point on the slide, I think, is really what I wanted to illustrate. Standard, why do we have this standard for patients? What difference does it make for patients? What difference does it make for clinical staff and also for the hospital? Then from the standards, the audit, just as I followed the same pathway before for designing audits, objectors, who's got a stake in the audit, we uncovered lab services, pharmacies, imaging departments, surgeons for some specialties, all those stakeholders that we had to engage in the audit. Who we including, who we excluding, how we collecting data, our measures, all those things carefully designed. Our team did the drafting, and the Ministry of Health Clinical Excellence Department, along with the Saudi experts, reviewed absolutely everything. Our measures were consistent with international guidance on how you write measures. Data collection, I've emphasized this before, how important reliable data are. We had a protocol for data collection, very extensive for each audit. Criteria for designing the data collection forms, making the forms as easy as possible to understand. Process for developing the forms, very, very detailed instructions for the data collectors. In fact, small books and workshops for the data collectors to make sure that they understood exactly how to collect the data. Our teams, I referred to earlier, multidisciplinary teams, workshops before and after the data collection at both stages with ongoing support for those hospital teams. We are so fussy about the reliability of data that we had independent validators of the data collected by each of our hospitals. They recollected, if you will, a small sample of the data from each hospital. We had a standard that there would be 85% agreement before our validation process. We had a big range of agreement. Afterward, everybody was very happy with the reliability of the data, no questions at all about the competency behind the data. If there are any questions at all about the data, the hospitals were asked to clarify them. And as I said, they got reports. Now, just really quickly, there are lots and lots of examples of improvements that came out of these audits. I'm just going to focus on a few involving the ambulance crew. Stroke patients the ambulance crews, we had a substantial increase in ambulance crews notifying hospitals as they were bringing patients to the hospital that the stroke patient was coming, so that care could be ready when the stroke patient arrived. Having National Institute for Health stroke assessments being completed when they should have been completed, patients having a stroke, making sure they have a swallow screening early after they arrive in the hospital, particularly before they're given anything to drink or anything to eat or any medication. Based on Australian data about the relationship of to outcomes of stroke patients, closely monitoring temperature and blood glucose level in the first 3 days after the stroke, we saw a big improvement in this aspect of care, and also prevention of venous thromboembolism treatment greatly improved. So obviously, good connections to outcomes. For MI patients, much faster, much more appropriate assessments in emergency care, much faster transfers to the cardiac cath labs, so interventions could be done on a timely basis. And also, in terms of outcomes, many more patients being referred for cardiac rehabilitation. Trauma patients, trauma leader there when the patient arrives, that was really, really important for timeliness of care. Important increases in relieving pain, in planning rehabilitation for the trauma patients, for sepsis patients having the whole bundle of care being delivered on time, substantial increases. So from the perspective of looking at these national clinical audits, just as they do here in the UK, we looked at what happened in Saudi Arabia. Well, for patients, better outcomes, better communication, because there is more education, more information shared with patients. I think the assurance that care in a hospital is consistent with best practice, that really had an effect in our Ministry of Health hospitals. The clinical care standards were very accessible, and so people could understand them. And I think overall more confidence that the care being provided is as good as it can be. The clinical staff, was very interesting impacts we observed on clinical staff when they participate in this kind of work, particularly for the first time. Welcomed having clinical care standards based on current international evidence. It just made it so much clearer what the expectation was for delivery of care. That scientific, really, really strong scientific approach to clinical audit, very highly regarded by the clinical staff, very respectful of that approach. The credible data being collected, the data being validated, no challenge about the data. Improvement. These audits drove substantial improvement. All the hospitals had significant improvement plans, which they proceeded to implement. I think particularly the multidisciplinary team involvement, I want to comment on, really, really helpful in changing the culture and using the care standards to hospital management. Again, I'm just going to say the benefits of clinical audit for hospitals. They're aware of the gaps in clinical effectiveness. They have information about record keeping. They see how how quality improvement is being applied to clinical care. The information systems use pathways and protocols, and they could share how well they were doing. So I think from that perspective, really, really helpful. So very, very quick summary of benefits. I hope you can see through the examples I presented. Better outcomes, better informed patients. From a clinical staff point of view, enormous benefits for outcomes, but also actually for hospitals and the healthcare system. There are enormous benefits for looking at clinical audit and taking it on board seriously in the organization. So, quick review through audit, linking outcomes from the evidence base, our UK experience, our Middle East experience. This is me. I'm very happy to answer any questions and help from there on.
Perfect. Thank you so much, Nancy. That was a fantastic presentation. I think you have covered almost all areas of clinical audit. You shared what is important steps and then how it needs to be done. And then you have been doing it for so many years. So all credit goes to you and your team, and then you have adopted that as a good method within NHS. And that is how it is so strong and robust. So we'll quickly, Nancy, if you permit, we'll quickly take few questions. There have been an active participation. First of all, they are asking, they're so impressed with your work and the presentation, they're asking for your presentation.
Oh, fine. It's there with you, so feel free to share, no problem.
So there is Priyank Tyagi, who is basically asking, is there a voice of patient in clinical audit?
Absolutely. And I demonstrated to you through our national clinical audits require patient representatives to have their say in what's important to them from a patient care point of view. And often our national clinical audits actually gather data from patients. At local level, it depends. A lot of local clinical audits actually do go directly to patients and gather evidence from patients. Absolutely. In fact, I've worked with patient groups and asked them for their opinions about what clinical audit should be done and how it should be done. And they're enormously helpful. They have very strong opinions and very strong experiences from being patients, and very, very happy to collaborate. So yes, patients should have a voice in clinical audit.
Very good, thanks. Is there a participation? How does UK work? Is there a national audit which is made mandatory?
Of the 50 audits I listed, about 25 of them are absolutely mandatory for the National Health Service organization, NHS organizations. They're just part of, you don't get paid, you don't get your money coming down from on high if you don't participate in these audits. Others are voluntary. The ones that come from charities, the one that comes from professional groups are voluntary, but many groups participate anyway.
Very good. So in India, we have a culture where anything to do with quality, we look for quality managers or accreditation coordinators, which is good and bad. So the question which Sai is asking is, can we do clinical audit for single hospital, and what is the role of quality professionals?
It's a wonderful question. We here in the UK, we've created specialist staff to support clinical audit. I think because of the specialist skills you need, particularly around collection of clinical data and working with clinical teams on translating evidence-based practice into clinical audit measures. Our clinical audit staff usually are pretty well trained in quality improvement, so they guide our teams through the quality improvement process as well. If quality professional staff are going to be involved in clinical audit, I think our own experience is that the need for training, particularly on what makes clinical audit unique, and that the discipline around the data collection and how important getting that discipline right is. So yes, you can use the quality people, but make sure, and you can do clinical audit at local organizational level, but you need the skills to do it.
Very good, thanks for that. The next question which Sri Parna is asking is, can you give an example of a clinical audit so that they understand the methodology? So you did cover in your excellent talk. Would you like to share anything more than what you had covered?
A good example of a, well, in our, gosh, it's hard to pick. In our stroke audit, for example, in Saudi Arabia, our stroke audit was based on international evidence. And so some of the things, I'll just give you an example of some of the things we looked at. We looked at, for example, is the hospital informed that the stroke patient is on the way so that the stroke interventions the stroke expert team can be ready when the patient arrives, because we know that means the interventions can happen faster, and therefore the outcomes of the patient are going to be better. If the thrombolysis or thrombolytic therapy, whatever they're going to provide, is provided faster, the patient is going to do better in terms of the stroke. So speeding up the care of the patient, that's what our audit focused on, getting the ambulance crew, getting the emergency department, lining everybody up to deliver the right care. One of the interesting things we learned in the stroke audit, I referred to this very, very briefly. First was swallow screening for stroke patients. What we uncovered in a lot of our hospitals is that staff were not aware of how important this is to the patient outcomes. What we know from the evidence base that patients who have a swallow dysfunction, if they have a stroke, have a higher probability of developing complications like pneumonia. And they sometimes don't recover that well from those complications that could have been entirely avoided if we had simply done the screening to see if the patient is able to swallow properly before the patient was given food and so on. And we learned that a lot of our patients didn't understand how important that swallow screening was. So they were waiting for speech therapists to come along and do it after the patient had been admitted, not realizing how important it was. So our audit, pulling from the evidence base the bits that are really, really important to outcomes and giving feedback to teams about where they can improve. I hope that helps as a further example.
Yeah, that actually helps. This is a very frequently asked question. How frequent we need to do clinical audit? They need to know numbers. Is one good enough? Is two good enough? It's one hospital.
It kind of depends on who we are now. If we're if you're a large hospital with clinical services, I just have to take a deep breath and say, you probably have more than one clinical priority to work on. So how many audits? Then it becomes a matter of workload. How many can you manage all the way through the improvement process? Our clinical services here in the UK, gosh, a typical very, very big NHS hospital probably does something between, across all their clinical services, probably do about 200 audits a year, 200 to 300 audits a year. Some of them are very substantial, some of them are very small, across all the clinical services. Each clinical service, this is Nancy taking a guess, probably does something like 3 audits a year, 4 audits a year, depending on how big they are and their ability to do audits, their capability of doing audits. We used to have people trying to do an audit every month, and we said, no, that's too much. Spread it out over time, because each stage takes time, including the review of findings, the analysis, and the improvement process. I think it's a matter of workload.
No, that's very substantial. The amount of audits which gets registered and which you do is phenomenal, and that's a very large number.
That's a hospital that probably has close to 2,000 beds, for example. Large hospitals, yeah.
One question which has been asked from Juan is, what is the difference between a clinical audit and a clinical governance?
Clinical audit is this activity I've described. Decide what best practices, see how well you're doing it, and act on the findings. Clinical governance is here in the UK. It means something very different. It is here in the UK in law. It is legal accountability by the people who operate the healthcare organization for all the quality and safety of care provided in the organization. That means that our chief executives are legally responsible and accountable for the care provided to all their patients. Our boards of trustees are legally accountable. That's governance. So our governance programs tend to include clinical audit, but they also include quality improvement, patient satisfaction, evidence-based practice, patient safety, all those other activities as well. But what distinguishes governance is the legal accountability. You can go, if you're a chief executive and you haven't run your organization and they're not providing quality, you will have actions taken. In fact, our chief executive, to be honest, our chief executives lose their jobs if they're not doing an oversight job. If they're not doing clinical governance, they lose their jobs. And that's happening.
Thank God this is not there in India. Many lose their jobs.
I know it's scary, but it does
That's
happen.
very interesting, because that is how you lay down a good culture and lay down a good governance structure. It was really interesting. I learned a lot from you, and it was very interesting to hear you. And thanks for giving us this opportunity and sharing your expertise. It was really wonderful.
Well, you're most welcome. I've enjoyed it enormously. Thank you. And thank you for the invitation to begin with.
So over to you, Lalu.
Thank you. Thank you so much, Sanjeev sir, for that. And Nancy, wonderful presentation. And our audience, I'm sure you engaged with them well, a lot of questions. And I take this opportunity to invite Father Johnson. He's the chairman of our healthcare division, to present the certificate of appreciation to Nancy. Over to you, Father.
Hi, Dr. Nancy, an excellent session. Thank you so much. In the name of all the participants spreading over 17 countries, I very happily presenting CAHO Certificate of Appreciation to Dr. Nancy Dixon. Thank you. Thank you so much.
Thank you. Thank you very much. I'm very honored to receive this certificate. Thank you.
Thank you so much for joining us. Indeed, it's been a real privilege having all of you. Nancy, once again, thank you from CAHO for taking your time and for being with us.